Good afternoon. My name is Cassie Beisel, and I am the Senior Advocacy Officer with the Melanoma Research Foundation. The MRF is proud to be the largest independent organization dedicated to melanoma research and empowering and educating melanoma patients to advocate for melanoma funding and societal change. I am also a three-time cancer survivor, one of those being advanced melanoma. I was diagnosed in 2011 and presented with a large lymph node under my arm, did a year of interferon, and really benefited from the resources that the Melanoma Research Foundation was able to provide for me. And as a survivor and my passion for the MRF, I knocked on their doors and they hired me. And now I am proud to say that I run the advocacy program. This year, I am also honored to be featured as the 2021 #GetNaked spokesperson to encourage prevention and early detection, which is the topic of today's session. The Melanoma Research Foundation is thrilled to present our Ask the Expert series for the month of May, which is also Melanoma Awareness Month, and today is Melanoma Monday. This month's program is sponsored by dermtech. This series will be featured each Monday throughout the month and will cover a variety of topics to help educate and empower the melanoma community. The MRF knows that education is critical for patients making informed decisions about their care. That is why we are thrilled to provide this educational resource through our Ask the Expert series. The work of the MRF and continuance of providing educational resources such as the Ask the Expert series would not be possible without the support of our sponsors. This month's program is sponsored by dermtech. dermtech's mission is to transform dermatology with non-invasive skin genomics platform to democratize access to high-quality dermatology care and to improve the lives of millions. This afternoon, we are joined by Dr. Daniel Siegel, who will be speaking about the importance of early detection. Siegel is a clinical professor of dermatology at SUNY Downstate and is a former president of the American Academy of Dermatology. He is also in private practice with Long Island Skin Cancer and Dermatologic Surgery in Smithtown, New York. Dr. Siegel received his medical degree from Albany Medical College in New York and subsequently completed his residency in dermatology at Parkland Memorial Hospital in Dallas, Texas. He then pursued a fellowship in Mohs micrographic surgery and dermatologic surgery at Baylor College of Medicine in Houston, Texas. Dr. Siegel also earned a Master of Science degree in Management and Policy from the W. Averill Harriman School for Management and Policy, State University of New York at Stony Brook. As a New Yorker, I'm very familiar with that school and holds an advanced certificate in labor management. Dr. Siegel has served on many professional organizations and has published more than 100 articles and book chapters in major medical journal textbooks. Dr. Siegel received the 2013 American Association Public Policy and Medical Education Award and the 2012 Clinical Educator Award from the 2012 Winter Clinical Dermatology Conference. Before we begin this presentation, please know that we encourage people to use the comments section to ask questions, which will be addressed at the end of today's presentation. The information presented today is for informational and educational purposes only. The MRF is not making a recommendation or endorsement of any drug, device, or treatment, or that any particular drug, device, or treatment is safe, appropriate, or effective for you. Questions regarding any drug, device, or treatment should be directed to your healthcare provider. We would encourage everyone to visit melanoma.org to utilize free resources like our treatment center finder. We also have a free Ask the Nurse service where patients can connect and ask questions. Now, I'm going to turn it over to Dr. Siegel to share more about the importance of early detection within a melanoma diagnosis. Dr. Siegel? Oh, Dr. Siegel, I think you're on mute.
Sorry there. My apologies for being muted there. Uh, Again, I am delighted to wish you all a happy Melanoma Monday. And Cassie, thank you for that very nice introduction. And let's just get into it. Let me just click the right button here. I do serve on the dermtech Scientific Advisory Board, and I serve as a consultant to the company. And I'd like to tell you a bit about dermtech. An important thing that they're doing right now is if you go to dermtech.com/pledge, for every pledge to get a skin exam, dermtech will donate $5 to MRF and other nonprofit organizations focused on skin health. So go ahead and take the pledge. Now let's talk about genomic testing. I mean, this is the sort of thing that if you're as old as I am, which I'm 64 today, this was all fantasy stuff when I was growing up, to be able to make diagnoses by looking at your DNA and your RNA. This is neat stuff. So we'll talk about this, and we'll talk about what is here today now, which is really, really cool. Now, early diagnosis, genomic testing can help you make a diagnosis of cancer long before you have symptoms, because you don't need a lot of abnormal cells to be present and be producing abnormal RNA and DNA. And if you make that diagnosis early, you can save lives. You can also fast track treatment, because if you get an immediate rapid result, you can go ahead and immediately remove the tumor, reducing the number of biopsies and the number of subsequent procedures. So you can save time, and not only save a life, you can save time, and saving time means you have less salvage and more conservative care available. And of course, pharmacogenetics, a hot topic you hear about in the news every day. Basically, it's genomic testing to help determine what medication and dosage will be most effective and most beneficial for the individual patient. And again, also there's objectivity. Genomic testing provides objectivity to existing subjective diagnostic paradigms. When you have pathology done on a tissue specimen, sometimes it is so obvious a first-year medical student can pick up the slide and look at it with just a naked eye and tell what's going on. But most of the time, it takes a skilled dermatopathologist to stare at the slide, ponder, look at the cell shape, the cell structure, and even among the best of hands, for instance, in melanoma that we're talking about today, about 17% of the time, the experts don't always agree. The likelihood is they will agree that something is not good and may be progressing, but whether it's already melanoma, it's progressing toward it, there's still not clear goalpost yet. Genetic testing gets around that. And lastly, what is so appealing to so many who don't like needles and knives is the genomic testing that DermTech's assay can do is non-invasive. Basically, there's no cutting, no blood, no pain, and it's something that could be done in the privacy of your own home during the pandemic. Now, just a little background on genomic testing that's transforming cancer diagnosis and treatment as we talk about this. For instance, in breast cancer, genomic testing facilitates the diagnosis of tumor subtypes and guides therapy selection. And that is here and now. That's the present. Now, clinical decisions traditionally have been made on patient age, the cancer stage, and the tumor grade, but accurate, far more precise diagnosis of the tumor subtype with genomic testing helps guide the selection of targeted therapies that can mitigate disease progression and essentially treat the patient with as few side effects as possible. And you improve the prognosis, and again, you can avoid the toxicity of chemotherapy or the adverse effects of prolonged endocrine therapy in situations where they are not needed. For colorectal cancer, genomic testing enables early disease detection. And for people who are reluctant to undergo colonoscopies, the reluctance can create delays in diagnosis, whereas the non-invasive genomic testing greatly improves screening rates and enabling prompt and accurate diagnosis. And lastly, more widespread disease detection reduces death and reduces disfigurement from extensive surgery. Prostate cancer, another common cancer, genomic testing guides the decision to biopsy. The conventional tests, such as the PSA, have low specificity, leading to unnecessary biopsies. In men with an indeterminate PSA or DRE test, genomic testing may detect prostate cancer more accurately and better evaluate the risk of aggressive disease. So genomic testing supports the decision to defer invasive biopsies that can have these serious negative health effects. all of these are important reasons why genetic testing is so neat. Now, cancer is a genetic disease, and it begins with a cell mutation. And what a cell mutation simply is a point in the cell's DNA where instead of the DNA being read and RNA and proteins being produced downstream accurately, a misread because of a replacement of one base in the DNA could lead to abnormal proteins, abnormal growth. And here's just a cartoon example of it. You have these mutated cells, and then the cells divide, and they divide again, and you go from 1 to 2 to 4 to 8, and much more cells accumulate. And you finally reach a point where you can see a lump or a bump. But think about it, when you're seeing that lump or bump, which is out here, this obvious visual change area, all the way on the right, imagine if you could have gone back here where you could have diagnosed it earlier, that if you could have diagnosed it yesterday or today, it's a whole lot better than waiting until tomorrow. Very important because yesterday or today is far better for getting rid of that cancer early on. Now, the DermTech PLA, a breakthrough new tool for dermatology, and the technology that goes on in the DermTech labs is very sophisticated, but what happens to you as the patient is simple and painless. And with the DermTech assay, you can identify these genomic changes before you see the changes that you can say, oh, yeah, that's definitely a melanoma or very likely a melanoma clinically, and that the pathologist can then see under the microscope. This can help you do it even earlier, and it lets you sample the whole lesion. And we'll teach you all about what we mean by that. And you can catch your early stage melanoma earlier. And this on the right just shows what the patch looks like. And that's actually the actual genomic material. The surface dead skin cells are on there. And that's where the assay is done. So very simple. You start with the smart sticker, and this samples across the entire lesion surface. And this adhesive tape, it's a fancy scientific medical sort of scotch tape, lifts 1.5 milligrams of skin tissue painlessly. And it has enhanced adhesive polymers that preserve the tissue for shipping to the DermTech Gene Lab. The analyses then, both RNA and DNA analyses, are done from the lesion sample. It's extracted right from that bit of dead surface skin, and you look for the RNA associated with melanoma. And when there's enough material to look at, the PLA plus looks for the TERT promoter, a DNA mutation that gives either further sensitivity and more clinical decision support. And the beauty of this is you get a report that gives you actionable results. It's not going to say, well, maybe biopsy. It'll tell you what's going on, and you can probably go ahead and treat if you need to. And on the other hand, if nothing needs to be done, if it's all benign, there's no scar, there's no cutting, there's no bleeding. Now, to understand how this all works, it's important just to think about how cells divide and differentiate. And what you're doing is you're looking at a complete and objective assessment of genomic changes before you can see the funny looking mole. You don't want to wait until you have this big, ugly black growth that is an absolute melanoma. You want to diagnose early. If you take a look at the cartoon here, you'll see the basal lamina, that's the bottom of the epidermis, that's the surface layer of your skin, that's where it meets the dermis. And those cells in the basal layer, the ones that are lined up, sort of like bricks all lined up here, those cells divide and the cells migrate their way up, and they flatten as they go higher up, and they go through different layers. They start in the basal layer, they go through what's called a prickle layer, and they go through a granule layer, and then they go through become stratum corneum. And what you're getting is you're catching anything that's going on in the base, you're getting that sampled at the surface. So you're seeing 100% of what's going on across the lesion. Now, if we compare the DermTech PLA, the proprietary lab analysis, to standard DermPath, we find the DermTech samples the entire lesion, where standard pathology looks at 1 to 2% of the entire biopsy. You get additional objective genomic information with the assay versus getting subjective visual criteria, which, as I mentioned before, there's about 17% or so of unusual pigmented lesions for which pathologists aren't always sure what's going on. And the PLA measures changes that can't be seen visually, where standard dermatopathology needs the changes to not only be in the area of biopsy, but also be in the sections looked at. And that's a very important concept. Think of this underwater photo as being like the DermTech Smart Sticker collecting RNA and DNA across the entire lesion. You see those bubbles coming up? Well, what you've got here is whatever's going on in the depth rises to the surface. But unlike a bubble that just pops and disappears, as skin cells migrate to the surface, they flatten out and stay adherent until the body sheds them, usually a process of around 3 weeks. And this lets anything going on in the depth where all the action is be reflected on the surface. In contrast with standard dermatopathology, think of that as a loaf of bread where the sample is sliced like a loaf of bread, but you don't look at every slice. You may look at one slice here, one slice there. And think about it this way. If this were a loaf of raisin bread, if I pulled out two slices and I looked at the crust and I said, there are no raisins in the crust on these two slices, therefore there's no raisins in the crust anywhere, well, that's not really a good way to assess margin. And by the same token, if I say I see no raisins in these two slices, well, that's like saying no melanoma is seen in the specimen examined. But if I took that biopsy off you because I'm suspicious, I have to wonder if they're just looking at the wrong place. We're getting around that by sampling everything. Now, the report we get back is a pretty straightforward report. It looks at the gene expression, whether it's positive or negative, and you have the link and the PRAME genes. In this case, the link was detected, PRAME was not, but it tells you whether you've got one or both, which plays a role in your risk factor. And if there's enough material to run the PLA plus, which looks for the TERT DNA, then that will also have an effect on the gene expression and the risk on here. But a straightforward report. And again, if there's sufficient material, you get the PLA plus. If there's not sufficient material, you just get the regular PLA, but it gives an indication as to what, if anything, needs to be done as a next step. So you get answers, you don't watch and wait. So you now have an additional tool to find out whether borderline suspicious lesions are benign or malignant. With the addition of dermtech, you get that whole picture. You can test clinically atypical lesions that you think are suspicious. And in addition to continuing to biopsy what you deem to be obviously malignant, you can go ahead and make many decisions based on this non-invasive assay. And this chart just shows, from left to right, a conventional mole, the fleshy common moles that we all have a dozen or so of. Nobody biopsies those. You know what they are. They're not suspicious. But then you get the atypical mole, the one that may be a little larger than the others. It may be more flat than fleshy, may have irregular borders, irregular colors, all the ABC warning signs you've heard of so many times before. But the question is, if someone's covered with many of those, which one do you sample? How do you choose? And often something will stick out as being an ugly duckling, something that is different than the rest, a little larger, a little faster growing, a little more variable. Well, in that case, you can simply do the PLA and you can find out what's going on before you have all the changes of melanoma. Here, melanoma in situ, early melanoma, obvious melanoma. Again, I'm not going to do a dermtech PLA if you come into me and say, show me a spot that's an obvious melanoma. But if I'm scratching my head and saying, that's suspicious, and once that word comes out of my mouth, you probably are thinking you don't want to wait. Some people want to do anything they can to avoid surgery or avoid a needle, and they say, let's wait, let's watch, let's observe. But if you suspect a melanoma, you don't want to wait. And this lets you have the best of both worlds. You can get an answer without pain, without bleeding, without needles. So what do patients think about this? 74% of patients surveyed would love a non-invasive alternative to a biopsy. No surprise there. And 87% of patients surveyed believe genomic medicine interventions are beneficial. 69% of patients surveyed said they would request the non-invasive PLA test instead of a biopsy if given a choice. And 80% of patients surveyed would be upset if this alternative to biopsy was not presented to them as a possibility. Again, this is how medicine changes. Things advance, things change, diagnostic approaches change, therapeutic approaches change, and you want to stay up to date, especially when you can avoid pain and bleeding and needles. Now, just a couple of patient comments. One person said, I've had more than 10 surgical biopsies and have the scars to show for it. I was so excited that there was an option to test without getting cut. After a few days, I found out the test was negative, nothing to worry about. A lucky person there. C. Skaggs said, I'm a melanoma survivor and have had more biopsies than I can remember. I'm so encouraged by your technology. Thank you for your help and for what you're doing for patients like me. Well, thank you, dermtech. Now, Bobby Joe said she requires biopsies every 6 months and it's extremely stressful. My dermatologist used the dermtech PLA, and so far it was a great experience. Someone else said, I like that it focuses on early detection and not as a tool to support, not replace my dermatologist's decision making. So, again, this can help out. And especially most of you are probably home right now with the pandemic still going on. So, if we're doing telemedicine, which I've done a lot of the past year and a half, and sometimes it's great. People have great camera, great lighting. But if someone looks like they're witness protection, where you can see their outline, you can't see any details, but they're telling me about a mole that popped up and it's rapidly changing, and they can't come in to be seen live. Well, in that case, a PLA can be ideal. Now, just reviewing the different ways for one to screen and diagnose melanoma. The DermTech PLA is painless and it can be done at home. Again, putting that patch of tape on the area, following the instructions that come with the kit, anybody can do that. You don't need to be a rocket scientist or even a PhD. You just need to be a normal person who can read instructions very simply. And it samples 100% of the lesion. Biopsy is not painless. It hurts a bit. You can't do that at home. And the sampling is far less than 1%. Reflectance confocal microscopy is another painless approach, but you can't do it at home. It involves a large machine. It does look at 100% of the cells in a given plane, but it is looking again at a cellular level, much like a biopsy. It's not looking at a molecular level. So if you think you might benefit from a DermTech melanoma test, please contact your dermatologist or primary physician about that. And now we have lots of time for questions. I hope we have some good questions out there. So I will stop sharing the screen. This just shows what goes on inside my head. And Cassie?
Thank you so much, Dr. Siegel, for providing our community with a thorough overview of the importance of early detection, especially in melanoma diagnosis, and how genomics can play a role in this detection. We do have a few questions from our viewers. The first is going to be, what are other options available to patients other than non-invasive tests you reference? Is a biopsy still conducted if needed to secure the final diagnosis?
Well, if the non-invasive test is pure negative, neither of the base genes or the TERT is positive, then you probably don't need a biopsy because that's benign. There's no markers of any cell mutations. On the other hand, if you get a triple positive, I would go ahead and treat on that. I wouldn't even spend the time biopsying because whether or not it's obvious melanoma, we know those molecular changes on that are there already. Again, if it's single positive, one may or may not go ahead. It depends on the circumstance. But generally, if it's a single positive, I would go ahead and I would, at that point, obtain a biopsy. Now, I say obtain a biopsy. If this is on the back or the belly of a 60-year-old man, and I would say, well, we can biopsy, but we're pretty sure something's evolving there. Let's just go ahead, take a little bit of a margin, take a little extra tissue, just get it done with. Many patients would do that. If it's on, let's say, the cheek of a 15-year-old girl, well, we might go ahead and there might be a psychological tendency you want to do a confirmatory biopsy. But if triple positive, I would still be very tempted to get a clear margin. But again, I could take a narrow margin because we may be catching it early enough that the pathologist doesn't even find anything abnormal in the sample looked at. So I think there's lots of ways to see it. And again, this could well replace a biopsy for many patients.
That's some great advice. Thank you so much. The next question, what are some frequently asked questions that patients bring to you when seeking advice on a spot of concern?
Well, the question that patients often pop it is, can it be cancer? And when it's pigmented, can it be melanoma? Those are the big questions that pop up. And of course, not all melanomas are pigmented, which makes my job a little more difficult, which is where the history comes in. Because if you come in with a funny looking spot and you say that, it's been there since you were 3 years old and it hasn't changed and kind of grew with you and it hasn't changed in the past 5 years, I'm a lot less excited by that. On the other hand, if you come in with this irregular spot and you swear it wasn't there 6 weeks or 2 months or 3 months ago, well, my suspicion index goes up very high. And if I look at it, I take out a derm light, which is a cross-polarizing magnifying device, and I take a look. And if it's a melanocytic lesion, it has any suspicious features, well, the DermTech is a great way to make the diagnosis, confirm that diagnosis, because again, I'm looking at something that may be the size of your pinky nail, And when the pathologist looks, they just do a handful of slices, that loaf of bread we talked about. Whereas the derm tech, you're getting everything rising up. So you're getting whatever's going on below is represented. So we're going to find it and then we can treat and treat it early. So we have a small scar, a much smaller scar than you get if you delay for months. You need a wider excision. You may have lymph node involvement by then. The goal is with melanoma is to treat early.
That is absolutely correct about early treatment and prevention. So we've got a lot of great questions coming in. Somebody asked, what is the difference in the time it takes to receive results in this non-invasive test versus a biopsy?
Well, the non-invasive test is a couple of days from when the lab gets it, I believe. I don't have the exact number of days. So again, the question is it going back to your doc, how quickly they get back? But it's generally if you're biopsied or if you're derm tech tested on a Monday, you may well have results by the end of the week or early the next week. On the other hand, a biopsy can be greatly variable. Some of the excellent derm pathology laboratories will turn biopsies around in 2 or 3 days. Others can take more than a week. In fact, one of the issues that goes on around the country is the American Academy of Dermatology and other dermatology groups are constantly pushing to allow the physician to choose the best laboratory. You don't want your specimen sent to a generic laboratory where a general pathologist who may not be comfortable reading pigmented lesions is reading. You want it read by an expert in reading skin specimens, and that's important. But again, the turnaround times can be comparable, but one involves getting a needle, getting cut, the other one does not.
And you were just talking the question before a little bit about positive, and I think it'd be really good. And one of the questions was what does triple positive mean exactly to the layperson?
Okay, well, you've got those three genetic markers. You have the link, the prime, and the TERT. The link and the prime are from RNA testing, the TERT's from DNA testing. And if all three are normal, that's negative. If any one is positive, that becomes a positive result. But two positive means a much higher likelihood of having melanoma. All three are positive. It's a much higher. It's better than the eyes of the best clinicians out there. So if you've got a triple positive, that's not something going to dawdle over. And again, this is where clinical judgment comes in. If you've got if you've got a 2 week, well, there's no one's taking 2 week vacations nowadays except staycations. But if you've got a 2 weeks planned on a cruise and you had a single positive and the lesion was a little suspicious, I'd say enjoy the cruise. If you had a very funky looking lesion that, sends off bells in my head that a good chance it's melanoma and you're a triple positive, I'd probably say, let's just have you a little less active in the cruise, but get this in the bottle. Because melanoma is one of those cancers that can spread through the lymphatic system or through the bloodstream, and you don't want to delay. In contrast to basal cell skin cancers, which you hear about, basal cell cancers spread almost like think of a candle melting into a bucket of water where the wax drips, but it's all connected. It's not going to spread through your body. Melanomas can, and there's a point, and this may be a simplistic way to look at it, but there's a point when all those abnormal cells are clustered together, and then there's a point where the cells start to meander. So if you can get that off before it's meandered, you can save a life. So we don't want to dawdle in that case.
Thank you for that explanation. That was a really good analogy and really simplified that. I think we have time for another question or two. So, you're talking about gaining samples, biopsies versus the derm tech testing. Why does a biopsy not gain as much of a sample as the non-invasive sticker test would?
Okay, when a biopsy it's taken, that little tiny piece of tissue goes in a bottle. Well, the pathologist cut through vertically because with melanomas, your diagnosis is best made on a perfectly vertical slice. So you can look at both the cells and where the cells are in relation to all the other structures. But also those slices that are cut are a few microns thick. So in other words, if you want to think of it this way, I mean, most of when I said micron, people probably started texting and saying, what's a micron? It's a thin measure. Basically 1,000 millimeters in a meter. A micron is 1,000th of a millimeter. It's a very thin piece. So if you're taking the slicing machine and you wanted a slice to look at every single slice, you could be turning the crank on the slicing handle all day and you'll get these ribbons of sections that will, for something that the size of a pencil eraser will run, many feet long. It's not feasible. So a biopsy looks at a random sample. They generally will cut the biopsy. If it's a little plug or punch like a pencil eraser, they'll cut it in half. You have some vertical sections through the middle and some from closer to the edges, but you're looking at a tiny, tiny sample. So that loaf of bread, let's say you live in the Midwest and think of it this way. If you have a loaf of bread that goes from Chicago to Milwaukee, and that's sort of the equivalent if you blow up the biopsy. And imagine I run along that whole route and I just pull out 5 slices. And I'm making a prognosis that, or making a statement that could affect your life based on looking at a tiny, tiny sample. It's not really good. It's just like when they do political polling, it's a sample, but if you make a mistake, people lose bets and people get a little upset, but you don't lose your life. Whereas melanoma, if you make a bad mistake, you can lose your life.
Wow. Well, thank you so much for that. And I think that's unfortunately all the time we had for questions, even though I know there's a few more and we'll try to get those answered offline. But this concludes our first Ask the Expert session sponsored by dermtech. If you are looking for more resources, please visit the MRF's educational resource page on our website at melanoma.org. The second Ask the Expert session will take place next Monday, May 10th at 3 p.m. Eastern Time, 12 p.m. Pacific Time on our Facebook Live page, which is right here. You're on it now if you're watching, and which will hear a presentation from Dr. Scott Drew, dermatologist with Dermatology Associates Mid-Ohio, who will be sharing all about skin cancer and melanoma. Again, the MRF would like to thank our sponsor, dermtech, and Dr. Siegel for their time, presentation, and expertise. We will see you all again next Monday. Have a great Melanoma Monday. Goodbye.